Hi guys, welcome to my YouTube channel. I'm Dr. Asmita from KMC Manipal. Today we're going to be discussing fetal growth disorders from the book Williams Textbook of Obstetrics, the 26th edition. The topic we're going to read is a spectrum of normal fetal growth. On one end lies growth restriction, one end there is macrosomia, and let's get into it. So what is normal fetal growth? It can be divided into three phases. So you can take around imagine, like, although it's written 16 weeks and 32 weeks, what I like to take is first trimester, second trimester. Here hyperplasia growth happens, here hyperplasia and hypertrophy, and after in the third trimester you get hypertrophy is the main mechanism by which growth happens. The corresponding growth rate, this is something important. So like I said, I remember it, the first trimester the baby grows by 5 gram per day, then after that it's around 15 gram per day, and then it's 30 gram per day. So this you can use if you have at around 36 week you have a growth scan where the baby was around 2600 grams. If the mother comes at 38 weeks, you don't have a scan machine, so how likely, or if she comes in labor, so how much the baby weight will be. So this has been 2 weeks, and by 30 gram per day you can tell it'll be around 420. So if you take 400, 3 kgs. So that is how you can assess. Okay, now here in this paragraph the normal thing is given is that the growth velocity peaks at 35 weeks. Okay, yeah, the importance of serial sonography when abnormal growth is there is of concern because it's not so sensitive to it. Okay, so you can see here. Now what is the normal birth weight? Now for determining what is the normal birth weight, the gestational age assessment is very important. Okay, now you can use sonographical methods and other methods and derive what is the gestation age. So that is there. So here they have told the gestation age estimated by the last menstrual pain by obstetric method. So near term, the obstetric method overestimates the gestational age. Okay, so if you're getting maybe like after at around 39 weeks, you've done a ultrasound and you're getting gestational age around 39 weeks, it's likely to be more. So that's why we say initially, early on, when we say dating scan is done, the earlier the scan is, the better, the correct it is. So that is what I'm trying to say here. The book is trying to say here. Now then, what is the physiology behind the fetal growth? Now there are multiple factors to it. There are maternal provision, placental transfer, and then there is also the fetus's own growth potential. Now the role of insulin-like growth factors is very, very important here, and it's not really understood well. Now these growth factors are produced by all organs, and one more hormone that is involved in this is leptin and adipokines, which are invariably derived from adipose tissues. Okay, and they also, fetal leptin concentrations rise during gestation and they correlate with birth weight and neonatal fat mass. Okay, now second thing is fetal, what they have seen is that the maternal glucose availability is also have a potential to affect the fetal growth. So although if you see fetal, like the restricted fetuses, the fetuses in which growth is restricted, they do not typically show pathologically low glucose. Okay, so fetal growth restriction in response to glucose deprivation only after long term severe maternal caloric deprivation. Okay, they have, or conversely, hyperglycemia can result in excessive growth. So what you can get is, if maternal deprivation is there, FGR is unlikely to happen because the fetus will derive nutrition from the mother. But if there is hyperglycemia, in addition to the fetus's own ability to derive nutrition, the fetus will be big. So there might be excessive growth. Now there was a hyperglycemia and adverse pregnancy outcome study, HAPO study, in which they found elevated cord C peptide levels, which reflected fetal hyperinsulinemia, which reflected high birth weight. Okay, so this is something, C peptide is the hormone which gets released when insulin is also released. So this is what maybe they are trying to say here, that like even in women whose threshold levels were higher but not high enough to call diabetes. Like if you're diabetic, you're normal. If their glucose levels were here, in their fetuses also, level of cord C-peptide, and there was hyperinsulinemia, and there was greater birth weight. So doesn't matter that if the mother has diabetes or not. If her baseline levels are still high, she can still get high birth weight. Okay, now second, obesity is also very important in this because there is a greater expression of fatty acid binding transport proteins within the trophoblast. What happens due to it is there is abnormal accumulation of lipids can result in placental inflammation and dysfunction. And see, placenta is the key here. So obesity is also something. If you have obese mothers, there can be FGR. So now let's go to fetal growth restriction. Now, how do you understand fetal growth restriction? You have to understand that there is a criteria that we have given, and there can be false positives and there can be false negative diagnoses. But when you have a standard definition, what you do is if you apply it to if you have a definition, you are likely to detect more people. Even if there are false positives in it, you are still likely to pick up the people who actually have the disease, and that's actually much better than missing them out. So according to the definition of ACOG and Society for Maternal and Fetal Medicine, you can tell that FGR is either estimated fetal weight less than 10th percentile for gestation age, or abdominal circumference less than 10th percentile for gestation age. You have to know this is something that you're doing in utero. That's why you're saying estimated fetal weight or abdominal circumference less than 10%. Okay, so here now next is you have to differentiate FGR from small for gestational age babies. You know, a baby which is constitutionally smaller but does not have any pathology associated with it, because there could be some sonographical error or something like that. So SGA is basically the birth weight. SGA is basically the birth weight which is less than 10th percentile. Okay, so this you have to remember. Then this and all you know. Then we move on to, in a review of more than 8,000 studies at the Parkland Hospital, they found that neonatal mortality and morbidity rate only at birth weights at or below 3rd percentile. So even if there is less than 10 percentile, less than 3 percentile is much more alarming change. And if it's associated with Doppler abnormalities, it becomes all the more alarming. Okay, now although FGR babies post-delivery as neonates can show metabolic derangements, small but normal neonates do not show evidence of postnatal metabolic derangement. Okay, so this you have to remember. Now how do you detect it? So there are 3 main tenets to it. The first is you have to tell the accurate gestational age, which is very important. Okay, second, if the pregnancy is low risk, if she just like maybe a primigravida, multigravida with no risk factors like diabetes, hypertension, something like that, then you do an abdominal examination after 24 weeks. Okay, and when the fundal height lags by 3 or more than 3 centimeters, so you know how this is your pubic symphysis, this is your umbilicus, this is around 20 weeks. So when you take an inch tape and measure, so if you're getting here 15, so this is 15 weeks, you're getting here 20 weeks, 24 weeks. Okay, so according to your LMP, gestation age is maybe coming as 30 weeks, but when you take your symphysiofundal height, you're getting maybe 26 weeks. So the lag is more than 3. So then you can suspect FGR. Now there are pregnancies in which there is risk for FGR, like there is hypertension, there is any other infections or any other history of any FGR baby, something like that, any chromosomal anomalies, any structural abnormalities in the fetus. You can take sonography, and that is very helpful and to detect FGR, especially at 32 weeks. Okay, and you have to do every 4 weeks to assess fetal growth. Now, like I said, uterine fundal height after 20 weeks is a very important screening modality. If measurement differs by 3 centimeters in the absence of any obvious explanation, it can be FGR. Okay. Now, this is what is the pathophysiology behind FGR. This is one of the major obstetrical syndromes, defects in early presentation. Okay, so usually you know now how there are trophoblasts, and in the vessels these trophoblastic invasion happens, which causes low resistance vessels. In this there is abnormal trophoblastic invasion. Okay, this same similar mechanism is involved in the preeclampsia also, pregnancy induced hypertension also. There also this part of the cycle of fetal development is defective, and that can lead to PIH. And here also you can see FGR, so you can understand why PIH and FGR might happen together, because there is a common point here. Now there are other enzymes like atrial natriuretic peptide converting enzyme, chorin, remodeling of the uterine spiral arteries, all of these things, but we are going to focus on this only. Now next we come to risk factors. Okay, so this table is a very beautiful table. As per the lady, poor gestational weight gain, she's coming to you for pregnancy, she should be getting 10 to 12 kgs. Okay, and if she's not gaining as much per week, every week when she comes she should at least gain 1 kg, especially near the term. If that is not happening, that can lead to FGR. If initially also there is, you're suspecting toward weight gain, nutritional, some deficiencies you can suspect. If the lady is herself height is short, nutrition is poor, there is social deprivation, there are eating disorders like bulimia, etc., then you can suspect FGR. Fetal malformations can be there, which usually we end up detecting, so we never reach a point where we have to screen FGR, but by chance in places where there is not good screening, or women don't get ultrasound appropriately, or do not get appropriate antenatal care, you can miss out on these, and you can detect these fetuses as FGR fetuses, and when they are born you can find that there are fetal malformations are present. Then there are maternal medical conditions, so PIH, diabetes, anemia, not anemia per se, but if there is severe anemia, placental or cord abnormalities, PIH हो गया, placental bilobeta हो गया, certain things, other cord abnormalities में one vessel, single umbilical artery हो गया, ठीक है, genetic abnormalities of multifetal gestation can also called FGR. Now weight gain during pregnancy is positively correlated with fetal size. Okay, and especially among women with gestational diabetes, weight gain is associated with both neonatal birth weight and adiposity. In contrast, during the second and third trimester, less than that recommended by institute. Okay, so for 6 months, okay, not this. Now what you have to see, if you give micronutrient supplementation, the only if they were assigned only iron and folate, offerings of those receiving the supplement had lower risk of early infant mortality and low birth weight, and improved childhood motor and cognitive. That's why the whole Indian system of giving iron folic acid, where we stress so much on iron folic acid, is important, because when you supplement these women, there is evidence that there is lower risk of early infant mortality and lower incidence of low birth weight. Okay, and the motor and cognitive abilities also include. But other micronutrient supplements may not be so useful. Okay, socioeconomic factors we have discussed only. One disease which is definitely, one vascular renal disease which is definitely restricts fetal growth is, you can say, is your maternal ischemic heart disease. Okay, with 16% risk of having SG in newborn, and chronic renal. So the heart and kidneys are very important. Okay. Now pre-gestational diabetes may have congenital malformation, or there can be some deprivation. As such, it might not lead to FGR. It's more related with macrosomia. Okay, chronic hypoxia, if mother has, there is asthma, cyanotic heart disease, pulmonary disease, cigarette smoking, living at high altitudes, also can lead to restriction of fetal growth. Anemia, like I had said and I was wrong, does not impair fetal growth. Okay, anemia does not impair fetal growth. Exceptions can be sickle cell and other inherited anemias. Okay, so this is something that you have to remember. So now there is one more syndrome that we are aware of, which is antiphospholipid antibody syndrome, antiphospholipid syndrome. Okay, in this, there is a two-hit hypothesis that initial endothelial damage is there, which is followed by intervillous placental thrombosis. Okay, now all of this, or women with more than one type of antiphospholipid antibody at higher risk of FGR. Okay, and the strongest association is with anti beta. तो बीटा टू बेटे को ग्रो नहीं करने देगा. दैट इज हाउ आई रिमेंबर इट. Anti beta 2 glycoprotein antibody positive is higher correlation with this. Now in placental and cord abnormalities, you have to remember that this happens, FGR happens because of uteroplacental insufficiency. Now there can be chronic placental abruption, there is extensive infarction, there is chorioangioma, there is filamentous cord insertion, umbilical artery thrombosis. All of these can be there. Okay, if there is abnormal placental dysfunction, implantation, that can also lead to FGR. ठीक है. Uterine malformations can also link to impair fetal growth. Okay, now multifetal gestation is obviously definitely correlated with FGR in one or the other fetus. Now medications which are very important, you can have exposure to certain drugs, alcohol, tobacco, have relation with FGR. Even some anti-epileptics, it's not given here, but just telling you, anti-epileptics like even valproate, although it's not given in pregnancy, but that if a woman is taking it and she gets pregnant, you should not stop it abruptly. Okay, so valproate. Now maternal fetal infections, okay, that can be multiple times. The best known are rubella and cytomegalovirus. Okay, they can both promote calcification in fetuses and related with worse outcomes. Okay, now in primary cyto-CMV infections, no severe cases were observed when infection occurred after 14 weeks. Okay, so this is also very important. In the first trimester, CMV infection is dangerous. Okay, then you have tuberculosis and syphilis, which also is related to fetal growth restriction, low birth weight. Congenital syphilis is also there but in this, paradoxically, placenta is large because there is edema. Okay, congenital syphilis is usually related with preterm birth. Okay, and because there is preterm birth, there is low birth weight. Toxoplasma is also there, which is associated with FGR. So CMV, TB, syphilis, toxo, and malaria cause low birth weight and poor fetal growth. That's why malaria prophylaxis is very important. Okay, then we come to congenital malformations. Congenital malformations, like I told, the birth defect which is most commonly linked with FGR is gastroschisis, and that a third of the babies had birth weight less than 10 percentile. There is also congenital cardiac abnormalities, which increases the risk of FGR. Okay, now genetic abnormalities. With trisomy 13-18, the risk of small for gestation baby is very great. With trisomy 18 is 80%, with trisomy 13 is 50%. So if someone were to ask you which trisomy is mostly linked with low birth weight, you will say 18. 8 में weight नहीं होता, like that, 18. Okay, in the combination of fetal abnormalities can be FGR, can be there, hydramnios can be there. Okay, so this thing you have to remember. Now confined placental mosaicism is recognized as a cause of FGR. So this can be an MCQ somewhere if you are seeing it. Basically, the genetics of the placenta plus fetus are like, there's a mismatch, it's not very similar, so that can also lead to FGR. Now if FGR is there, fetus with slow but progressing estivatal mate is more reassuring than one that has plateaued growth. Okay, it's okay if the babies grow, like you do serial ultrasounds and you see there is some weight gain, there is some growth, the graph has not become a plateau. It is actually a good sign, and you can merely choose to observe. Okay, then I wanted to do this part in very detail because it comes down to management. but I think the video will become very long. So this part, the management part, we will continue in the next video tomorrow. I hope you guys were able to learn something from this, and yeah, I'll see you later. Good night.